This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to Fellows Conference. This morning we have Maggie Wang, who's going to be presenting on arrhythmias in pregnancy. Maggie is one of our clinical investigator pathway fellows who is in her second clinical year, and she is going to be presenting on arrhythmias in pregnancy. Take it away, Maggie.
All right. Thank you so much for the introduction. So again, today I'm talking about arrhythmias in pregnancy. And I was told I should show this slide at the beginning of my presentation. So here it is. And then to start off, we're going to go over the objectives of this talk. So the first objective is going to be to explore the physiological changes during pregnancy that increases the risk and burden of arrhythmias. Second is to identify antiarrhythmic medications that are considered safe for use during pregnancy and lactation. And third will be to review evidence-based approaches for the management of arrhythmias during pregnancy. So we're going to start with a case. We have a 40-year-old woman who presented to an outside hospital with abdominal pain. She was incidentally found to be 39 weeks pregnant, and so she was transferred here for a high-risk OB. Cardiology was consulted for management of atrial fibrillation as well as frequent PVCs. On arrival, she was asymptomatic, denied having any chest pain, palpitation, shortness of breath, lightheadedness, no volume overload symptoms. Her vitals, she was afebrile, blood pressure was 137/84, heart rate was 80, respiratory rate was 18, and she was standing well on room air. Physical exam was notable for irregular heart rhythm, as well as trace peripheral edema to her bilateral lower extremities. And then labs were pretty unremarkable. Maybe the magnesium was, on a lower side, but otherwise, there was nothing remarkable. Her labs, her renal function was normal. For her past medical history, she had a history of atrial flutter, for which she underwent a CTI ablation back in September of 2021. She also had a history of proximal atrial fibrillation that was actually getting harder to control over the past several months in the setting of this pregnancy that was unknown at the time. She also had a history of hypertension, diabetes, obstructive sleep apnea on CPAP, morbid obesity with a BMI of 75. She had never been pregnant before, no prior surgeries, and then her outpatient medications included Nadolol, diltiazem, dofetilide, and Xarelto. And so this is her EKG at the outside hospital. I don't know if there's any fellows in the audience that kind of want to take a stab or kind of look at this and what you guys think. Also, I can't see who's in the audience, by the way, so Dr. Coley might have to help me out with that part.
Anyone want to take a stab at it? I don't want to call anyone out.
Yeah, I actually asked a few of the fellows before, and people kind of gave me different answers. So I would be curious to kind of see what you guys think.
This is Francisco. I'm looking at it from the cell phone, so it's gonna be a little tricky, but I would love to measure the R to R intervals to see they're constant or not. It
So
looks some
they're
activity.
irregular.
They're completely irregular.
Mhm.
Then I'll probably say is AFib, and then with some PVCs.
Yes. Anyone else wanted to chime in?
Could be also MAT.
Yeah, so Francisco, you're correct. I think some other fellows thought because you could see the P waves really clearly. Some people were saying a flutter at some point. Other people were saying sinus rhythm with PACs. But this is coarse atrial fibrillation. Because if you look at the P waves, they actually don't march out, pretty irregular, which is characteristics of atrial fibrillation. And then the irregular R to R interval is also another hint. So this was a course AFib with heart rates in the 110s with frequent PVCs. And then upon arrival, as you can see, she actually had converted back to normal sinus rhythm with heart rates in the 80s, but she still was having some frequent PVCs with kind of different morphologies. And then this is her echo. So I'll play it really quickly. Essentially pretty unremarkable. It was read as EF of 55 to 60%, normal diastolic function, and her left atrial size was normal as well. And so I'm going to share a couple of questions. Originally, I was going to put up a short poll to kind of gauge everyone's current understanding of the topic, but just found out that we're not going to be able to do that. So if you guys could kind of put your answers in the chat box, just so we could get an idea of where everyone's at. And then at the end of the presentation, we'll revisit these questions and go over the answers. So the first question is, which of the following medications should not be used in pregnancy? Is it A, dofetilide, B, nadolol, C, diltiazem, or D, all of the above?
So far, we have a bunch of A's.
A's, okay.
But that's only 3 of us, so. Oh, we have a D, another D,
How about C?
A. We got a C. Who is that?
A mystery EP doctor.
Yes.
Really? Okay. Well, so, Dr. Kohler, sorry, I can't see the chat. So are you saying there's majority A's or?
At the moment, we have mostly A's. We have a B and a couple of D's, and then obviously our esteemed EP, Dr. Lloyd, C. So perhaps we should go with that.
Okay. Interesting. Interesting. Okay, and the second question is going to be, what is the preferred anticoagulation during pregnancy? So it's A, DOAX, B, low molecular weight heparin, or C, warfarin.
I'm just looking at the chat. We have a pretty solid B, and then Dr. Ogany pointing out that it does depend on the trimester.
Okay. 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 Well, great. Again, we're gonna come back to this case at the end of the presentation. Okay, so now to begin with a little bit of background. So you may have heard that unfortunately maternal mortality rates in the United States have been increasing over the past 2 decades. In 2022, it was estimated that approximately 22.3 maternal deaths occurred for every 100,000 live births. So that's quite a lot. While the exact contribution of arrhythmias to the increased maternal mortality rates remain unclear, we do know that the incidence of arrhythmias, especially atrial fibrillation during pregnancy, have been increasing over the same time period. This is largely due to increased maternal age accompanied by rising incidence of cardiovascular comorbidities such as obesity, diabetes, and hypertension. We also know that pregnancy itself is known to be associated with increased incidence of arrhythmias. So, for example, premature atrial and ventricular contractions have been demonstrated to be more frequent during pregnancy compared to the pre-pregnancy period. This is because of the physiological changes during pregnancy actually promote arrhythmias. And so these changes include pregnancy-induced cardiovascular changes, such as increasing heart rate and blood volume, which then leads to greater end diastolic volumes, and subsequently the cardiac chambers start to dilate, which then leads to increased risk for arrhythmias. And then just like for you guys to know, the effective blood volume does usually increase by at least 50% during pregnancy, but in twin pregnancies, it could be up to 100% actually. And so again, these result in stretching of the atriums and the ventricles, which actually leads to promoting arrhythmogenesis. And a part of that is because in addition to the dilation, it also activates like stretch sensitive ion channels. And then the second mechanism in which pregnancy promotes arrhythmias is the pregnancy-related hormonal changes, such as increasing estradiol, progesterone, and cortisol levels do predispose pregnant patients to cardiac arrhythmias. In fact, estradiol and progesterone increases the number and responsiveness of the adrenergic receptors within the myocardium itself. And then lastly, as pregnancy progresses, there is a shift from vagal to higher sympathetic activity. And that's why you kind of see that the basal heart rate usually increases by 10 to 20 beats per minute during pregnancy. And so it's this increased sympathetic tone that leads to either new onsets of arrhythmias or can worsen burden of previous arrhythmias. Now we're going to review the different classes of medications used to manage arrhythmias in the peripartum period. We're going to start with the beta blockers first, which are going to be your first line treatment for many tachyarrhythmias during pregnancy. So most of the studies on maternal beta blocker therapy use are based on pregnant patients with hypertensive disorders of pregnancy, where the fetal growth could also be affected by the underlying condition, in this case, hypertension, and not necessarily the drug itself. However, there was one study of beta blockers prescribed for maternal cardiac conditions with a separate analysis of pregnant patients with isolated tachyarrhythmias as the indication that demonstrated significant effect of beta blockers on fetal growth after adjusting for other potential confounders. And so because of this study, the side effect that we worry about the most with beta blocker use during pregnancy is intrauterine fetal growth restriction. And so how I think about it in terms of what is safe and what is not safe is for beta blockers, they do cross the placenta and can be found in breast milk as well. But the amount that crosses the placenta or gets excreted in breast milk is largely determined by the degree of protein binding, with lower protein binding allowing more of the drug to cross the placenta or be excreted into breast milk. So metoprolol and propranolol have the highest degree of protein binding and thus are the safest and the preferred beta blockers to use during pregnancy, while atenolol, for example, has the lowest protein binding and thus have the highest risk of fetal growth restriction because more of it is getting to the fetus. And so I created this table for you guys. Blue indicates what's safe to use during pregnancy. Yellow is you can use it during pregnancy, but you should use it with caution. And then red is definitely what you should be avoiding in pregnancy. And so again, metoprolol and propranolol are your preferred beta blockers. Atenolol, you should try to avoid. If you have to use nadolol, you should use it with caution. And then carvedilol, it's a drug that a lot of us use, but unfortunately there's just insufficient data on the safety of its use during pregnancy. And so generally because the data is unknown, we don't recommend carvedilol during pregnancy. And then the second class of medications I'm going to be talking about is calcium channel blockers, specifically non-dihydropyridine calcium channel blockers. And so this is either verapamil or diltiazem. It's going to be your second line agent for management of atrial fibrillation, atrial flutter, and supraventricular tachycardia. Verapamil and diltiazem are both associated with maternal hypotension, fetal bradycardia, and fetal growth restriction. And so you have a lot more side effects, which is why it's your second line agent as opposed to your first line agent, such with the beta blockers. Verapamil has been used without significant risk of teratogenicity, while the use of diltiazem is a lot more controversial due to animal studies showing some fetal abnormalities such as cardiac, skeletal, or retinal abnormalities that can happen with its use. And so currently, based on this box that I've created for you guys, so verapamil during pregnancy it's kind of in the safe to use with caution zone. And then diltiazem, you can use it, but you should use it with caution. Now moving on to the sodium channel blockers. So I just kind of had this out of order because lidocaine, which is actually a class 1B drug, is going to be your first line treatment in the management of VT during pregnancy. And this is because there's just a lot of well-established safety profile for lidocaine. And then mixilotine, which is, we kind of think about as like the oral version of lidocaine, it's actually recommended to be used with caution. And the main reason for that is because there were some case reports of mixilotine use in pregnancy having reported lower APGAR scores. And then also there's just less data with on mixilotine being used during pregnancy, and so that's why it's recommended to be used with caution. But for lidocaine, it's safe to be used during pregnancy or during lactation. And then we have your class 1A drug, procainamide, is a second line agent in the management of VT, and it has been used without reported teratogenic effects. Although, again, similar to mixilotine, the data for procainamide, there's just not as much data on it. And so because of the limited data, it is recommended to be used with caution as well. Both of these drugs, by the way, crosses the placenta and can be found in breast milk. And then you have your class 1C sodium channel blocker, flecainide, is very safe to use in both pregnancy and during lactation. It's in fact the treatment of choice for when the fetus itself has SVT. And so the dosing that we usually give to the mom to treat fetal SVT is flecainide 300 milligrams once a day. But in general, there has been, it's been safely used to treat both maternal and fetal arrhythmias with animal data and rodents confirming no teratogenic effects at 50 to 80 milligrams per kilogram per day dosing. And then now moving on to your potassium channel blockers. So sotalol is considered safe during pregnancy and lactation with only a small risk of fetal bradycardia. There has been no teratogenic effects documented when we're looking at animal models. Ticacin or dofetilide, on the other hand, should be avoided in pregnancy, and this is mainly due to a lack of human data, as well as in animal models, we have seen significant bradycardia as well as skeletal abnormalities in the fetus. And then amiodarone, which I know is a medication that a lot of us reach out for in a lot of when we're managing arrhythmias. And in fact, it is probably the most potent and effective drug for managing arrhythmias, but unfortunately, it's generally considered a last resort option in the setting of life-threatening arrhythmias when we're looking at pregnant patients. And this is because there are significant adverse fetal effects with amiodarone, including fetal hypothyroidism, growth retardation, and prematurity. With that said, though, keep in mind that the infant only receives a fraction of the mother's weight-adjusted dose, so approximately 11%. And so when you have to use amiodarone, you want to try to use the lowest dose possible as well as the shortest duration possible. The potential fetal adverse effects, like I said, depends on the maternal dose and duration. And then when you are using amiodarone, you also need to monitor the thyroid function in the infant as well. And so here's a table. Sotalol, again, safe to use during pregnancy and during lactation. Ticacin, amiodarone, you should try to avoid. And then these other two antiarrhythmic medications don't really fall into what the classes that we already talked about, and so I just kind of put them here. Adenosine has a very short half-life. It's very safe to use in pregnancy and during lactation, and it's in fact the drug of choice to terminate maternal SVT in pregnancy. And then we also have digoxin, which has a long history of safety in pregnancy as well. Keep in mind that the digoxin concentration is similar in both the mother and the newborn, and so you want to definitely be monitoring those digoxin levels if you choose to use it. Now, moving on to electrical cardioversion. And so direct current cardioversion in pregnancy is warranted in cases where you have hemodynamic instability or if you're unable to rate control medications itself. One thing to keep in mind is that cardioversion can cause uterine contractions, so there is a theoretical risk of preterm labor, and thus these patients should be treated in centers with the capacity to perform emergency C-section if needed. While the current that reaches the uterus is small, the amniotic fluid is actually a good conductor, and so there's also a small risk of inducing fetal arrhythmias, and hence fetal monitoring is suggested when performing cardioversions. But interestingly, energies ranging from 50 to 400 joules have been used in the past without fetal adverse effects. And then, of course, when you're placing the pads on the patient, you should try to place it away from the gravid uterus. And so these are just kind of two ways that you could be positioning the pads. And then for catheter ablation and implantable devices in pregnancy, generally it's recommended to defer ablations and device implantations to the postpartum period due to potential risk of radiation exposure to the fetus. However, this was something that I learned that I didn't realize what we could also do, but in certain experienced centers, they could actually try to do these procedures with very minimal to no fluoroscopy. And so usually they will try to use anatomic mapping systems as well as intracardiac ultrasounds to try to reduce that fluoroscopy exposure. And then now moving on to anticoagulation. The use of anticoagulation for atrial fibrillation or atrial flutter during pregnancy isn't well studied, but a lot of these recommendations are extrapolated from data from pregnant patients with mechanical valve replacements. Low molecular weight heparin is the preferred anticoagulation during pregnancy because it does not cross the placenta and has a safer profile. For patients who are deemed at high risk of thromboembolic events, and for those patients that have to be on warfarin, warfarin can be used throughout the pregnancy if the dose level is less than 5 milligrams per day. However, if they require a higher dose level, then it's recommended that in the first trimester you use low molecular weight heparin, and then in the second and third trimester you could resume the warfarin at the higher dose. And this is because warfarin is associated with increased risk of miscarriage as well as congenital anomalies. And then in regards to DOAC, because we get this question a lot, whether DOAC is safe or not to use during pregnancy. Unfortunately, because of minimal data for the use of DOAC in pregnancy, currently we don't have a recommendation for it. Generally, we say to not use DOAC in pregnancy for now, given the limited data, just because it is known to cross the placenta. And so low molecular weight heparin is still your preferred choice for anticoagulation during pregnancy. And then now just to kind of put that all together, I kind of created this chart. I know it looks a lot, but we'll go over it together. But this is just a table that I created for kind of management of some of the common arrhythmias that you may see in a pregnant patient. So PVCs or PACs, those are very common in pregnancies, but they're usually benign. And so a lot of times you don't have to treat them. But if they are very frequent or symptomatic, you can consider beta blockers. And again, preferably you want to use metoprolol or propranolol. For SVT, for the acute management, you want to try vagal maneuvers first. And if that doesn't work and the patient is stable, adenosine is very safe to use during pregnancy. If they're unstable, then you'll have to do cardioversion, which can be performed safely as well. For the chronic management of SVT, the first line is going to be your beta blockers, and then your second line treatment is going to be your calcium channel blockers. If pre-excitation is present, then you want to think about also adding flecainide along with your beta blockers. For atrial fibrillation and flutter, for both acute and chronic management, your first line treatment is going to be beta blockers plus or minus digoxin. And then your second line treatment is going to be calcium channel blockers. If you want something for rhythm control and the patient has no structural heart disease, flecainide is going to be a good choice. However, if they have structural heart disease, as long as they don't have severe LV dysfunction, then you can reach for sotalol. And then again, in cases where you have hemodynamic instability or when rate control is unsuccessful with medications, you can do a direct current cardioversion. And then your anticoagulation that is preferred during pregnancy for those pregnant patients with atrial fibrillation or flutter would be your low molecular weight heparin. And then lastly, for the management of ventricular tachycardia in the acute setting, if they're unstable, you got to shock them. If they're stable, though, you could, your first line treatment is going to be lidocaine. And then if lidocaine doesn't work, your second line treatment will be procainamide. If they have polymorphic VT, remember to give them some IV magnesium. And then for the chronic management to prevent recurrent VTs, your first line treatment is going to be beta blockers. Second line treatment will be mixilotine, flecainide, or sotalol. And as a last resort, you could consider ablation versus amiodarone. And then sometimes for these patients, they do need to get a device while they're pregnant. And for those patients, it will be if they're having sustained VT that's difficult, sustained VT, or if they're high risk for a sudden cardiac death. Again, we do try to defer ablation and device implantation to the postpartum period. But when we have to do it, certain centers can do it with minimal to no fluoroscopy. And so these are just kind of flow charts of what I pretty much summarized in that table, but I just kind of want to show you guys just to know so that you guys know they exist. This is all from the Heart Rhythm Society Expert Consensus 2023 guidelines. So going back to our case again, just to summarize it in case there were some of you guys that missed it, we had a 40-year-old, 39 weeks pregnant woman who has a past medical history of diabetes, hypertension, OSA on CPAP, morbid obesity, aflutter, status post a CTI ablation, and paroxysmal atrial fibrillation on Xarelto, who was being consulted for management of atrial fibrillation and frequent PVCs. She was asymptomatic, hemodynamically stable. EKG scintillometry showed proximal atrial fibrillation with frequent PVCs, and she had a normal renal function. Her home medications include nadolol, diltiazem, dofetilide, and Xarelto. And so here are the questions again. Which of the following medications should not be used in pregnancy? Is it A, dofetilide, B, nadolol, C, diltiazem, or D, all of the above? So if you guys could put your answers in the chat box again, let's see what you guys think now that you have all this knowledge from this presentation now.
Maggie, I need to defend myself. Listen, A
Yes.
and C are both class C's, and C, first of all, diltiazem and nadolol should never be used together. I mean, that's silly. What we usually deal with is what's going to hurt the mom. So you take away dofetilide, that's going to hurt mom. Diltiazem always has an answer, and diltiazem's data for teratogenesis is pretty bad, and it's also not really good for breastfeeding. So I think it's always controversial. The reason I picked diltiazem, they're both class C's. I know you're following that guidelines paper, but I think I'd still say I would keep the dofetilide, because taking away the dofetilide in the mom is a lot more risky than just changing the diltiazem to more nadolol.
Yeah. Sorry, I think The reason why I chose these options was because this is what the patient was on, but I agree that it was a little bit difficult with these two. They are both class 3 or class C medications technically. Dr. Coley, I can't see the chat, so do you see what people are saying?
Just 2 A's that have come up.
Okay, it's okay. So I'll just go over the answers. So I think Dr. Lloyd had a really good point. This is based on what the Heart Rhythm Society guidelines are, but again, when we're doing clinical practice, there are a lot more nuances to it. Technically, the right answer here, based on those guidelines, was going to be dofetilide, only because it definitely is recommended to be avoided in pregnancy due to human data lacking, as well as animal studies showing teratogenicity with significant fetal bradycardia and skeletal abnormalities if given during organogenesis. Nadolol, it's not one of the preferred beta blockers to use, but if you do use it, you should use it with caution. And again, this is all about how much protein binding there is, which determines how much of the drug gets to the fetus. And then diltiazem, I think the paper or the guideline says use with caution, but it sounds like for Dr. Lloyd Stanford, for this particular case, he would prefer to not stop this because it'd be harmful to the patient since she's having a lot of paroxysmal AFib and had this history of where this AFib was like very difficult to control, which is why they actually initially switched her to Ticastin. She was previously on flecainide actually. But at that time, they didn't realize that she was pregnant, which is why they had chose Ticastin. And then again, if you're going to use a calcium channel blocker, you want to try to use verapamil over diltiazem just because there's a lot, verapamil has been associated with less teratogenicity than diltiazem. And then what is the preferred anticoagulation during pregnancy? I think, yeah, so if you guys could put in your chat box what you guys think now that you've had this talk. Yeah, I see a lot of B's.
Yeah.
Yeah, so I think this one was a lot more straightforward, more so because I think we have a lot more experience with this. And so your correct answer is going to be your heparin or low molecular weight heparin. And so it's preferred because of the safer profile as well as it doesn't cross the placenta. And then again, DOACs, the only reason we don't recommend it is because there's limited data on safety. We do know that it does cross the placenta. And then for warfarin, it's not preferred given it's associated with miscarriages and congenital anomalies. But again, if you have to use it, then you want to try to use a dose that's less than 5 if you are going to use it throughout all 3 trimesters. If you have to use a dose that's greater than 5, then the first trimester, you want to switch to a low molecular weight heparin. And then the second and third trimester is when you could switch back to that higher dose of warfarin. And so just kind of to summarize what happened to this patient. So while she was hospitalized, all her home medications were actually stopped: Nadolol, diltiazem, Ticastin, and Xarelto. She was actually started at that outside hospital on low pressor, 25 POQ 6 hours for rate control, and put on a heparin drip for anticoagulation. And then the heparin drip was stopped at midnight because she was going to have a planned C-section. She ended up delivering a healthy 8-pound baby via C-section without any complications. And then interestingly, after she delivered, her kind of arrhythmia burden, we started to, she wasn't having recurrent AFib anymore, and her PVC's burden actually came down a little bit. And so the decision after consult EP was to discharge her on the metoprolol and then resuming the diltiazem, which she was also on for blood pressure reasons. And then she actually ended up going home on a Xarelto because she didn't have any plans for breastfeeding. And then the decision to reinitiate Tikasin for rhythm control was actually deferred to outpatient. And I think a lot of this decision was mainly based on the fact that she wasn't a patient that followed with an EP doctor in our institution. And so since her outpatient EP doctor knew her really well, we decided to just kind of send her out and have them decide whether they want to hospitalize her again for that reinitiation of the Tikasin or if they had other plans. When I was chart reviewing, it looks like they actually decided to keep her off the Tikasin, and she had plans to have an AFib ablation as outpatient. And so some take-home points. Pregnancy-related hemodynamic, hormonal, and autonomic changes increases arrhythmia risk. Metoprolol and propranolol are the preferred beta blockers during pregnancy and lactation. Generally, you want to avoid amiodarone in pregnancy, use only as a last resort option in the setting of life-threatening arrhythmias. For anticoagulation, low molecular weight heparin is going to be your preferred agent. And then direct current cardioversion is warranted when there is hemodynamic instability or when rate control is unsuccessful with medications and can definitely be safely be performed in a pregnant patient. And then it is preferred that catheter ablation and device implantation be deferred to the postpartum period, but it can be performed with minimal to no radiation exposure at specialized centers. Here are my references. And that is it. I am open to any questions if anyone has any.
This is Dr. Eliazu. I've just recently joined faculty here at Emory and Grady, and I'm leading the cardio OP initiative at Grady because of the maternal health mortality issues that you highlighted, Maggie, especially in underserved populations. So I'm looking forward to meeting you guys and working with you all. And Maggie, that was an amazing talk. I love how you broke it down. Because really, when you're in these situations, you just want to know, what can I use, what can I not use? And so that was really great. I wanted to highlight that, for example, with beta blockers, labetalol is a big one that you're going to see because the OBs are so used to using that for blood pressure. Labetalol will likely be already started on these patients, and you sometimes you just up titrate it. Rarely do I see them start propranolol, and rarely do I start propranolol in these patients. Usually it's metoprolol, as you mentioned, Maggie, and then labetalol as well. And then I think if they're unstable, don't be afraid to shock them. That's that there's a lot of I think aversion about that, but you really have to think about mom first and do the safest thing for the patient. And so this was a really great talk. Yeah, great job.
Yeah, I think those are excellent points. Thank you for adding. I was curious, and I don't know if Dr. Lloyd, you'd be able to speak about this, but I personally don't have very much experience seeing like ablations or devices being placed during the pregnancies or pregnant period. And so at least what I was reading is that you can perform these procedures with minimal to no radiation exposure, but I don't really know exactly what the details are and how that's usually done. Or if is Dr. Lloyd still here? Let's see. Or is there any electrophysiology?
Yeah, I think he went off, but right before he left in his chat, he said fluoroless ablation is fairly standard.
Sorry, what?
Fluoroless ablation is fairly standard.
Okay. Okay.
The other thing I wanted to add, Maggie, with regards to some of these SVTs, I think with our patient, it was a little easier to diagnose. In some of these patients, remember, they're going to be young, so their heart rates are going to be very fast. It might not be easy to distinguish what exactly the rhythm is. And so as you mentioned, just, reaching for adenosine is very safe,
Yeah.
can definitely with diagnostic and therapeutic benefit in terms of managing the patient and then figuring out what is this arrhythmia. So.
Yep. That's a good point. Yeah. So and remember guys, all of these flow charts are very, very helpful, and they're all in that Heart Rhythm Society consensus guideline. And so you could always pull it up if you're like not sure what's the next step. And so sort of what Dr. Eliezu was saying is that, if you look at this flow diagram first, if you're thinking it's SVT, hard to figure out what it is, and it's during the acute onset, your first line, most of the time we do the vagal maneuver, but it doesn't work. And so if they're hemodynamically stable, adenosine is going to be your first line medication. And I know, like for this talk, I focus primarily with tachyarrhythmias, and the reason why is because that's, the physiological changes that occur during pregnancy tends to promote those tachyarrhythmias. When we're thinking about heart block, that tends to be more so in the congenital population. And so I chose not to, I just kind of focused on the tachyarrhythmias for this talk.
Well, if that's all we have, Maggie, thank you much. That topic that we don't always hear. I learned quite about meds that we can use, and also the importance of getting our EP colleagues involved, because there's obviously some nuance in there as well. Thanks again, everyone. Have a great Friday, and we will see you next week.
The preceding program is copyrighted by Emory University.